Okay, can you hear me? The sound is on. You're not just listening to my voice, but you're listening to it through amplification. That's good. Okay, first of all, thank you very much for attending this particular session. This is there's a lot of competition to get people to come here because there are prominent speakers at the same time. So thank you very much for that. And one thing about this session is that it's this is the EHiN conference, and there's a lot of interesting talk about interesting and fancy technology. There's a lot of talk about cognitive computing and interesting algorithms and a lot of very high-tech fancy stuff. And in many regards, this session is not about fancy technology. It's a lot. So you can say it sounds a little bit boring, and I might be starting off in a bad way here. But I think it's important to point out that this session, I believe profoundly, that the topic for this session is in many ways more sort of groundbreaking and has the potential to change healthcare to a larger extent than all those esoteric technologies. So, but I believe one thing that's important here, if we need to sort of embrace the potential of this kind of technology, is that we see it in the right way. I believe that you can see digital citizen services, if that is the expression that we're going to use, and it is the name of the session, so it is. You could either see it as some kind of a prolongation or an extension of the existing services. So when you talk about the patient or the citizen's ability to access the medical record, you can say that there's a law in place in most countries, also in Norway, where you have the right to access your medical information through the medical record. And you can say that you can enhance that, or you can make it digital, and you can make it easier for the patient. So and that's a sort of an additional service to the patient. But you can also sort of see it in a different way, and that's the way that I would encourage. That's the perspective that I would encourage that we take or see it through in this session. And it's a perspective that embraces this kind of technology as a sort of a larger trend, where you see the relation of the citizen and the healthcare services as changing, as fundamentally changing. And when the patient and the citizen is sort of enabled to do more things, for instance, access the medical record, there's a big potential to increase basically the treatment, but also change the sort of the hierarchy. Okay, so we have 3 speakers here today, and I think it's a very good mix between sort of academically well-founded, well-educated, interesting people that we have today, but also with a nice blend of practical experience, and I think that's very. It suits this kind of a conference and this kind of session very well. And I think just on a final note, I think that this particular session is very much in line with what we heard earlier today. If you attended the opening and if you heard our minister, I think I did take notes actually. I think the very first thing that he said, he had this kind of 3 speeches. It was a bit confusing, but the very first thing that he said, for me, it wasn't really well prepared. I think the other speeches were sort of prepared, but the first thing he said was that all of this is about getting people involved in the care, and I think that he talked a lot about empowering the individual citizen and so on and so forth. But what I think is interesting is that the first thing he said, without really sort of thinking about it, was getting people involved in the care. So I think this session is in line with the sort of the whole conference, and especially the health minister. I'm from the Southeastern Norway Regional Health Authority, as it is called in English, Helse Sørøst. På Norwegian, it's a bit easier to say. And I'm working with the regionalization of digital patient and citizen services. So you heard Katrine Lofthus, my CIO, talking a little bit about this earlier today. So that is my and our interest in this. Okay, I shouldn't take up more time. Sorry for spending a few minutes here, but I wanted to set the scene. So first up is Torunn Wibe from Oslo municipality, where she's head of the department at the Center of Institutional Care. And she's a nurse by training, and she has worked at the Oslo University Hospital. And she recently obtained a PhD, which was about the patient's use of clinical documentation. So that is in line with the topic. So if you're ready, please enter the stage.
Takk. Det litt sterkt lys her, så jeg skal ikke stoppe meg opp. My name is Torunn Wibe, and I'm a nurse currently working as a consultant at the Center for Development of Institutional and Home Care Services in the municipality of Oslo. Before this, I was working for several years in the geriatric department at Oslo University Hospital, where communication with primary care at patient discharge is an important part of the job. Information exchange between healthcare providers in the hospital by means of the electronic health record, and information exchange between healthcare providers in hospital and primary care has become one of my main interests, as well as information exchange between healthcare providers and patients. I finished my doctoral thesis last year, in which patients' access to information after discharge from hospital was a central theme. As part of my PhD work, I examined patients' experiences with the use of their health records as source of information after discharge from hospital. Unfortunately, I was not able to take part in the workshop yesterday about patients' electronic access to their health record. So for those of you who took part in the workshop, there is the risk that I will repeat some of the points made there. I have, however, read the report from the work going on in Sweden and the paper from the project in Northern Norway that was suggested as additional reading related to the workshop. And I must say that many of the patient experiences that are reported in these documents support findings in my doctoral thesis, and also findings in the international literature concerning patient access to their health record, which I have studied rather thoroughly during my work with the thesis. However, I will start by summing up some of the background for the increasing interest in patients' access to their health record. In the majority of developed countries, healthcare services currently offer short hospital stays, early discharge, and an emphasis on patients' activation and self-management. Patients commonly receive their healthcare from a wide range of healthcare providers. In this situation, poor communication between patients and healthcare providers, as well as between different providers, has come a focus in many health service complaints. Medical errors and failures to coordinate care, especially during transitions, have emerged as shared concerns for many countries. Narratives of missing referrals and gaps in information transfer are rather commonplace. In many countries, patients now have the right to access their own health records. In Norway, where my study took place, patients have had this legal right from 2001. The right can be seen as a part of a broader trend in healthcare, in which a higher level of education and the ability to access health information on the internet are contributing to more multifaceted and less paternalistic patient-provider relationships. However, caution has been raised concerning potential disadvantages of patient access to clinical documentation. It has been suggested that giving patients access may cause confusion and increase their anxiety due to both language and content of the documentation. Healthcare professional skepticism towards clinical documentation as a source of information for patients was also evident in a sub-study in my thesis concerning information practices of healthcare professionals related to patient discharge from hospital. I also saw that such skepticism was described in the report from Sweden referred to in the workshop yesterday. My presentation today is, however, mainly based on the findings from an interview study with patients who had requested a copy of their health record after a hospital stay. In this study, I made 17 individual face-to-face interviews with patients who had requested a paper outprint of their electronic health record after a hospital stay. In the hospitals where the study took place, there was no electronic record access for patients at the time of the study. Some more details about the study participants. 16 women and 1 man were interviewed, and according to the hospital archives, this reflects that much more women than men requested a copy of the record at the time of the study. They were aged between 28 and 67, and 11 of the 17 study participants had education beyond high school. What I was interested in finding out in my study was why people request their health record after a hospital stay and what significance they attach to what they read. A main finding was that patients wanted a copy of their health record in order to keep a sense of control. Getting more knowledge about their health condition and wishing to play an active role in their own healthcare were important reasons for requesting a copy of the records. The informants described reading their health records as a means to obtain a more complete version of their illness story, mainly by supplementing their own experiences with a biomedical description of what they had been going through. Informants were also concerned that important information would not be transmitted between different hospitals where treatment took place, or to their general practitioner or a specialist outside the hospital. So they took the role as a messenger or postman. Thus they personally brought their medical records to encounters to secure information transfer. Informants also wanted to check the accuracy of the records because they had discovered documentation errors during consultations with practitioners. The most common error was record mix-ups. For instance, that a note belonging to another patient had been put into their record. Consequently, they wanted to make sure that the rest of the record was correct. Just to illustrate a little this finding, one informant described as follows. I did have questions that I wanted an answer to when asking for a copy of my record, but first and foremost, my purpose was to pass on the record information to the other hospital where the birth was going to take place, to get help to decide whether a cesarean or a normal birth would be best. Another informant said, in hospitals, you know that things can go wrong or things get misunderstood. There are only humans working there, and they can make mistakes. Some of us like to have control and pose some more questions. As an anecdote, I may mention that the study participants were generally tolerant to the use of professional language in the records. However, the use of Latin, acronyms and abbreviations were emphasized as elements that contributed to difficulties in understanding the record content. The study participants were generally content with understanding things based on the context, and they did not have to understand every single word, as illustrated in a quote. One patient said, "Of course there are some expressions that I don't understand, but I understand it from the context. In any case, I understand the professional terms concerning what is relevant for me." Informants found that most of the content of the record was objective, informative, and in no way controversial. But for some patients, reading the record gave them a feeling of not being respected as a person. This feeling mainly occurred when the informants felt that healthcare professionals had underestimated them, had revealed their prejudice, or had a too narrow perspective on their situation. As described through two sub-themes, feeling underestimated and feeling misjudged. Some of the patients experienced seeing in the record that the healthcare professionals had not been open with them in direct communication. They felt that their concerns, for instance, of side effects of medications, were not being taken seriously when mentioning it to the doctor. When reading the record, the informants noted that the doctor had in fact agreed with them. This made them upset. "But why didn't he say this to me?" One informant said. "I just wanted to hear him say, yes, that might be possible." When reading the record, informants also experienced that healthcare professionals had wrongly attributed certain conditions, for instance fatty liver or obesity, to stigmatizing lifestyle problems that the informants claimed not to have. Informants found documented that what they thought to be an incorrect interpretation of their symptoms. One informant found that a physician had written about her heavy chest pains. "I think these pains may be of a psychological nature." This made her feel that she had not in fact been taken seriously. Despite some negative experiences, the study participants emphasized the overall advantages by patients' access to their health records. Findings from the interviews did indicate that the study participants wanted more flexible routines for the release of record documents than they experienced at that time. One patient said, "I'm not saying that you should force the health record on people, but it should have been easier to get it when you asked for it." A limitation of the study is the fact that the sample was self-selecting. The participants also had a relatively high education level. Although this might be representative for the patients who actually ask for a copy of their health records, one should be careful about generalizing these findings as being typical for patients' experiences with reading their record. Even if the low number of men recruited to the study might reflect the number of men asking to read their records in these hospitals at the time of the study, the unequal participation of genders is also a limitation of the study. Patients asked for a copy of their health records from the hospital to hand over to their general practitioner, or to be able to forward a copy to another healthcare organization involved in their care. These findings indicate that information flow between different healthcare levels in Norway is not optimal, or at least that patients do not trust that all the necessary information is being exchanged between their various healthcare providers. Access to their health record may increase patients' sense of control and enable them to make take a more active part in their care. However, the role of messenger is not a role all patients are capable of taking or even wish to have, and therefore improvements in information flow is needed even with electronic access for patients to their electronic health record. Despite the legal right that Norwegian patients have to read their health records, some patients in my study were afraid of seeming suspicious or displeased if they indicated that they would like to read their records. Offering patients electronic access to the records, as is done in Northern Norway now, represents a great advantage compared to a system in which patients have to stand with their cap in their hand, so to speak, and ask for a paper copy. Receiving a paper copy from the hospital archives also takes a long time in many cases. To conclude, I will emphasize that patients are privileged observers of the whole treatment process and might be underestimated resources in efforts for improved patient safety. Patient access to health records may contribute to the discovery of documentation errors and will bridge gaps in information transfer across different healthcare settings. Thank you for the attention. Any questions or comments? I don't actually see you, so.
So, are there any questions? I think we do have a microphone here, and we have a pen falling to the floor. Thank you very much. It's terribly difficult to see. This is, this microphone on this stage, I feel a little bit like Britney Spears when she's on the stage. Okay, I shouldn't elaborate too much on that. I can't really see any questions. So if you do have a question, you have to shout. All right. I do have one question. I do have several questions actually, but I think maybe I should stick to just one. And it's a sort of a down-to-earth question, because you have a lot of experience sort of investigating the experiences and the sort of expectations of these patients. But if you were to sort of conclude in relation to a term like patient empowerment, would you say that the patients who accessed or obtained the medical record were empowered? This going to be an easy question or a hard question? It depends on how you want to answer it.
Yes, I would absolutely say so. Even if some of them had some negative experiences by reading the record, I think it's better to know what is actually written there than not to know. Yes, absolutely in most cases, I would say that it's an empowering experience. Mm-hmm. many people say that the language in the record would be perhaps a disempowering experience when you read things that you don't understand. But the study participants here, they did not see that as a problem. No matter if they didn't understand everything, they preferred being able to read the record.
Okay, so they preferred it, but were they able to do something that they were not able to do before they accessed the record?
No, I think it mainly gave them a better overview over what had happened when they were in the hospital, and I think it's also an important perspective that they could control better what information was given to the general practitioner, for instance. That was a very important issue for the participants.
All right. Thank you very much. Please. And now for the next speaker, who is Elin Børøsund. I can't really say that in English, or in Norwegian for that matter. This is another nurse by training and another person who recently obtained her PhD. She's currently a postdoc at the Center for Shared Decision Making and Collaborative Care Research at Oslo University Hospital. So please come to the stage.
Thank you so much. I'm very happy to be here to present some of my work and thoughts about electronic communication between patient and providers at this conference. I am a nurse, as I was introduced, and in my PhD, I focused on e-health for self-management of chronic illness. One important part of self-management is to be able to consult healthcare personnel for questions and information when you need it. And at the present, most of this communication is still provided by telephone or in face-to-face encounters. I look forward to, in the future, to be able to have systems, good systems, secure systems for electronic communication in different healthcare settings as well. I'm now going to talk about lessons learned from several studies examining e-health, secure email in hospital settings. What have we learned? How do patient and healthcare providers use and evaluate such secure email? And I will also share some thoughts about implementation of these systems with you. I work at Center for Shared Decision Making and Collaborative Care Research at Oslo University Hospital. We are a center with researchers with different backgrounds, such as nurses and psychologists. And we have, in addition, IT developers, designers, information officers, and service user consultants among our staff. And these service user consultants are patient experienced people. This unique combination makes us able to create new innovative e-health solutions and test them in research studies. As you all know, this is not something new. The occurrence of chronic illness is increasing in Norway and the rest of the world. And in addition, as you all also know, the patient have shorter and shorter hospital stays with day and outpatient visits. And this leads to that patients have less time with us healthcare providers and must manage more of their care and questions at home. To offer patients healthcare services in the future, I think it's necessary that we offer them new ways to communicate with healthcare providers. Electronic communication between healthcare providers and patients can be provided through different channels. And what I'm going to share with you today are experiences of using secure email from own and my colleagues' research. There is growing interest among patients in using secure email systems. And people want to communicate with their providers in such a way, and many people expect it. In surveys on e-health in Norway, and people what they expect, conducted in 2013, 14, and 15, between 38% and 55% of the people asked stated that they would like to communicate electronically with a primary physician or like to consult e-health providers through email or chat. And studies have shown positive effects of using secure email on patient outcomes, such as reduced depression, increased self-management of disease, and increased satisfaction. Several primary physicians offers online communication, and there are reimbursement systems for such consultations. In hospital settings, however, still limited systems are available, and I'm looking forward to what's going to happen in near future. And we have limited experiences with use in regular care. In the studies I'm going to present results from, we design a secure email systems together with healthcare providers and patients. We use Bank ID as a secure login system. I will explain this for you now. The messages from the patient arrived in the email box of the coordinating nurse who had experience on the patient's diagnosis and had access to the hospital's secure electronic patient record. The nurses could respond directly to the patient or forward the message to another provider, depending on the question asked. That this provider could answer the patient directly or give comments back to the coordinating nurse, who then could compose an answer to the patient. These different options for communication flow were based on requirements from both healthcare providers and patients. It can be said to be a kind of a triage system, and the nurses was expected to have competence in answering most of the questions. And the other healthcare providers were comfortable in doing this, using this system. We performed several studies in the period of 2010 and 2014, including different patient groups. We tested this system in several settings in Norway, at different hospitals at Oslo University Hospital, Rikshospitalet, Radiumhospitalet, og Aker Hospital, at the Vestfold Hospital Trust, Tønsberg, at Sørlandet Hospital, Kristiansand, and the University Hospital of North Norway in Tromsø. We included different patient groups, such as patients with breast cancer, testicular cancer, advanced stage cancer, patient that had a liver transplant, and patient with diabetes, to get different groups. When we invited different hospital settings to participate in our studies, we met healthcare providers that were very interested but extremely busy. And several expressed to be afraid that opening up for this new way to communicate could cause an overload of email from the patient in a workday that was already full. In addition, they were skeptical about losing the personal meeting with the patient, and thereby maybe overlook some symptoms and signs that are used to give the patient advice and treatment. In, for example, one of the studies where we included patients with breast cancer, we initially asked 10 hospitals for participation. 5 were interested and get some more information, and at last 3 hospitals participated. And those who declined, they did mostly so because they were afraid they didn't have the resources to answer the email from the patients. So, when patients have access to this system, how do they use it? Of those who had access in the different populations, 22 to 42% used the opportunity to send secure email. The group that sent most emails was the women with breast cancer, who was recruited early after diagnosis. The users sent an average 1 to 4 email in the study period of 8 months to 12 months, so that wasn't so much. I initially presented that surveys show that about 38 to 55% of us are interested in this kind of communication. Our results, I think, fit pretty well in these matters. Another observation I would like to share is that patients read the answers from their providers several times. Some were in 2 times, 3 times, 4 times, 5 times. This information is still standing there after you have gotten it. So this is an important element of electronic communication, I think. It doesn't disappear like a telephone or a face-to-face contact. In one of the studies, we included women, as I said, with breast cancer, early after they got a cancer diagnosis. And here we looked at when the users logged on first and last time. And we observed that users logged on the system during the first week of access. And over 80% had logged on during the first 14 days after they got access. We also looked into how long they used the system. So if you look at the green line here, you can see that after 3 months, about half of the users stopped using the email service, even if they had access for 1 year. But after 3 months, half didn't use it anymore. And this, I think, may correspond to when you have a diagnosis, you have a lot of questions, and it's important to log on early and get your answers. And after a while, you have gotten the answers you need, and you don't need this service anymore. That might be one explanation. In the study with the women, those who had access to secure email reported significantly lower symptom distress, lower depression scores, and higher quality of life when we compare to a group that did not have this access. And this result was obtained even only 42% used the system. So what we have been wondering about, just having the access to such system can be a kind of assurance. You can reach your healthcare providers when you need it. So access might be connected to positive outcomes. But what are so the reasons for non-use of these systems? As only 22 to 42% sent email in these different studies, we were interested in reasons for non-use. And one of my colleagues interviewed 22 non-users among patients that had liver transplantation, testicular cancer, or advanced cancer, and reported reasons for not using these systems were that some felt that they didn't need this. They could have sufficient access to information elsewhere. And others stated that they preferred other type of communication, such as telephone or face-to-face contact. And the third was that some were hindered by technical issues, such as login problems. However, many reported to be satisfied of having this opportunity, even though they didn't use it. So, what kind of questions did the patient have? Several of the questions were related to self-management of their illness at home. They had questions about symptoms. Is this normal? How can I take care of my symptoms? Medication, questions about lifestyle, and practical issues. They also used this email service to double-check information. And as Torunn talked about, looking up your health record, to check up information, is this normal? And to give information to your healthcare provider. And some patients also used this email service to tell somebody how they felt. They told stories. They told about their worries without having a question. In interview with patients that used the secure email service, some said that they wish they had access to this kind of service earlier in their illness. How did so the healthcare providers answer these questions from the patients? The patients were told that they would get answers within 2 working days. And in most cases, they actually did. These 2 days answering time was made together with the healthcare providers. What can we offer our patients? And I think this is very important. We must keep our promises. If a patient is allowed that we will answer within 2 days, we shall do this. If not, they can get unnecessary worries. And most of the questions were answered by the nurses. In the study with the women with breast cancer, 82% of the questions were answered by the nurses, and the other 18% was answered by physicians. And the answer they gave, it was tailored to the questions. If a patient asked clear, concise questions, they get the answer in the same way. And if they told a story, the nurses and physicians acknowledged their story and their worries. I can see you having a tough time now. Hanging there. It will get better. They were cheering the patients. And a critique to online communication is that it cannot replace face-to-face interaction and might give a cold impression. What we saw looking at these questions and the answers in the study, where breast cancer patients were included, was that this communication indeed was person-centered. Health providers shared their knowledge and recognized the patients as experts in their own disease, and recognized their emotions in a caring way. And if a question couldn't be answered in email, they phoned the patient or set up a face-to-face meeting. We also interviewed both nurses, physicians, and other healthcare providers about their experiences of using secure email. Most were positive about using this service to the patient and thought it had in fact been fun to be a part of this. Some highlighted that it was a learning experience, reading these questions. They learned much about the patient, what they were asking, and sometimes they were surprised. Do they really wonder about this? I thought we had given a lot of information on this topic. And in addition, they also learned from writing answers themselves and for what other colleagues were answering to the patients. And several expressed that they were kind of surprised that so few used the service. All providers were positive to this triage system, with nurses at the front line, as nurses did answer most of the questions. Of course, there were also negative, less positive experiences. The log-on procedure was considered as cumbersome. And as this was a study, the system did not correspond with the electronic patient journal. And this is important to address when offering such a system in a routine practice in the future. And also the feel of need for such a system differed. In one of the units, the provider felt that their patients did not need this kind of email system. And this resulted in that few patients, in fact, were offered this service. In the studies I've now spoken about 40 healthcare providers with different backgrounds learn how to operate a secure email system. And to gain insights about facilitators and barriers affecting implementation of email service, one of my colleagues interviewed several of these healthcare providers. And the most important factor for implementation success was that the healthcare providers and managers believed in the tool as useful for themselves and their patients. When they had belief in the tool, it acted as a facilitator. And when this was absent, it acted as a barrier. And this was extremely important for implementation success. So when healthcare providers felt no need for the tool, either for them or the patient, they didn't contribute to implement the tool. Another factor that emerged was relating to different perceptions between patients and providers concerning patients' need, as I earlier told you about. The patient expressed satisfaction with having the opportunity to send email. And if they don't use it, they liked it even so. And this was not in line with some of the healthcare providers who did not recognize that the patient had a need for such a service. They just assumed, without asking the patient, that they didn't need this service. And management, engagement and support from key personnel such as opinion leaders were also extremely important for implementation success. When the manager didn't engage with the implementation and when there were too many negative opinion leaders, the implementation became kind of difficult. Finally, the degree of planning of the implementation process affected the implementation success. So the studies I now presented gave insight in different perspectives of use of secure email in Norwegian hospitals. Despite moderate use, access to secure email had positive effects on patient outcomes, such as reduction of symptom distress and depression, and increased quality of life. It might be, as I told you, that to simply have access, and I think this is important for all of us, to simply have access to this kind of service can do some good for our patient. We observed that only 22 to 42% sent these emails. And I don't think we will get overwhelmed by these emails from the patient when we are implementing in Norwegian hospital as well. And this is important to tell our healthcare providers. The triage system in our study was well accepted. The nurses had knowledge to answer such a service. And most of the healthcare providers thought that this was a nice way to communicate when they first started with it. They were skeptical in the start, but when they started, they liked this kind of communication. Their answers to the patient were characterized by care. The patient got answer on the questions and concerns, and their stories was acknowledged. Our research center are showing some of our other applications at the stand of the Norwegian Research Council. So I would like to welcome you all to drop into our stand and look what other things we're doing. So thank you so much for your attention.
Thank you, and thank you for keeping the time. And again, we do have a minute or two if there would be any sort of comments or questions. And now we have 2 questions. Let me just hand you the microphone, because then everyone can hear you. Tak.
I was wondering, even though you said that the answers were tailored to the question, was the kind of topics of the questions the same? Could some of the information maybe been reused that they were giving in the answers?
That's a good question. Initially, when we created this system together with healthcare providers, this was something they want us to make. And we had a system where you could keep the good answers on different topics. But in our studies with these patients, I guess about 150 patients altogether, I think, we couldn't reuse any answers. Not yet, but of course, if you have a larger volume, maybe you could reuse some information. And we also made it possible to attach some information folders from the different units, because that was asked for.
You were saying that it had a possible positive outcome on depression levels and quality of life. Couldn't it be possible that the association is the other way around? That less depressed patients are more likely to use this kind of service? Did you control for any other variables like education level or?
Well, we control for baseline outcome measures.
But
so baseline depression scores were controlled for in the analysis.
But still, patients becoming less depressed might be more likely to use the communication services.
It might be. I can't answer that. I'm sorry.
Any more questions? We have a question up there. If you can please pass on the microphone. Thank you.
I was just wondering about the organization of answering the questions. Did you pick a dedicated personnel that was responsible for answering emails, or were there could everybody in a ward or at a clinic answer the emails? And how do you imagine that being governed in the daily?
Yeah, that's a good question, because we allowed several different ways of doing this, and most of the units, they had a group, often 3 dedicated nurses that had worked there for some while that knew the patient and could answer the questions, and also dedicated physicians, nutritionalists, social care workers. So all were dedicated to answer this system, but it was a group, it was not only one, because then it would be too difficult to handle for them, they said, in vacations and when if somebody wasn't there anymore.
So it kind of have to be an organizational change as well as.
I think so, because this was one way of doing it with this kind of triage systems, and I guess it would be several more ways to do this electronic communication. But indeed, organizational change, I think, must happen along with implementation of e-health systems.
Thank you.
All right, thank you very much. And before leaving the stage, I have a present for you that the next speaker just told me, because I didn't really know. But thank you very much. And I also have a present for the former speaker, because I kind of forgot that. I didn't really know it actually. But here you go, and thank you. All right. Finally, we have our third speaker, Tove Sørensen, who is from Tromsø, and she's a project manager of the digital patient services in northern region, and she has many interesting things to say. And I heard some of them yesterday, but today she's going to talk specifically about the ability to lock the access to the patient's record. So this is another kind of sort of service to the citizen, that the citizen can not only sort of read about him or herself, but also sort of control or access the information about who is accessing information about the citizen. Thank you.
Thank you. Thank you, Nils. And I was told to tell you about the gifts. And now I know where they are if someone else is interested. Thank you very much. I'll talk very briefly about the why, what, how, and when it comes to patients' online access to their health records log. We call it tilgangslog in Norwegian. I'll do this presentation in English, but I might use some Norwegian words. Which is a service that is about to be implemented in Northern Norway by the end of this year. This is actually one of the services that's part of our roadmap when it comes to patient services in Northern Norway, which has to do with several aspects: patient empowerment, patient safety, but also quality control of the healthcare service. This tilgangslog has been part of the project that started up in 2014 with partners from all the hospitals in Northern Norway, Helse IKT, DIPS, and Directoratet for Helse. So, talking about this, I will very often get this question: why are you pushing a log service on patients? Don't they have enough problems? Well, we do this for several reasons. First, because it's part of the law that patients have a legal right to access their health record, but also the log of the health record. And it's also by law that healthcare professionals shouldn't read or access patient record data which they don't need in order to treat the patient or for administrative purposes. So it's a right that's been there for a very long time. Very few people know about it. They might contact the hospitals to get access to the health record, but very few know that they can also ask for the access log. But some people do. This is a quote from the Data Protection Authority report, which stressed that the health sector shall positively contribute to a strengthening of access control and logging of data. And finally, that the individual needs to keep oversight and control of information about himself. And this getting the control of what's happening in the hospitals is quite challenging, because although the logs are done, it's quite time-consuming to go through the logs. So there are actually 3 ways for the hospitals, as I see, or we see, that hospitals can have control of the access, and that's first is big data analysis of the logs, machine logs of data. It's awareness campaigns and training healthcare professionals, and then it's the possibility of giving patients access to the log data, because patients are most interested in who's actually been accessing their health record. Now, this is a service on helsenorge.no. It's a part of Min Helse, so it's the log-on site. I guess many of you have been there. Depending on where you live in Norway, you have different services available for you. But if you log in by secure mechanisms, we have several. This is very, very well known for Norwegians. I won't go into details. You get this first page with different services. Now, and I'm just saying this because there's a lot of confusion out there. I'm going to talk about the service called Pasientjournal, which is this one, and not about Kjernejournal. And those are, it's not because I don't like Kjernejournal, not at all, but it's 2 different services. Whereas Kjernejournal is a summary of your visits to the healthcare services, registered based on registered data. Pasientjournal is actual access to the data that is there in the hospitals. It's called Pasientjournal, but it's only, for the time being, it's only the journal on the hospitals, and it's in Northern Norway and Western Norway. And in US, they can access not through Helse Norge, but to a separate portal. I was saying, now, when you choose Pasientjournal, you can choose which healthcare region you are in, Helse Nord and Helse Vest. And then you get just a summary of the records you have in your journals. It's very simple. It's just a list, the date, the type of document, the author, when it was changed, which hospital, and so on. You can click on the document, you can save it, you can print it, and you can, when you log out, nothing is stored there. It's all in the original is in the healthcare service. Now there is an extra service within the Pasientjournal, and that is this tilgangslog. It's quite hidden. You actually have to look for it, but it is there. And when you press it, you get this access to the logs of the health records. These are in Norwegian, excuse me if people don't understand Norwegian, but I'm just going through some of the slides we're using in an e-learning course for health professionals. There are 2 levels. The first one is the level 1, where you can see what healthcare professionals has actually accessed your journal, and it's either a comment that someone has put there, like a free text, and they can say the reason why they have accessed the journal. Then the user can click for more information. It's hidden. It's not hidden, but it's called handlinger, and that can be a bit confusing. But handlinger means more information. And then you can see what kind of documents a person has opened. And the user can also sort the list time-wise. In level 2, gives an overview of what documents one person has actually opened. Sometimes it will be the person hasn't opened any documents, but you get the list of the documents. So you get who has opened your documents and what kind of documents have this person seen. In this access log, the reason for access will be there, it will be written. Well, you see, this is an e-learning course because we say we recommend everyone to write an understandable reason why you have access to the log, because this reason will be displayed for the patient on helsenorge.no. Now, how much information will be provided time-wise? When we started this patient access to their health record, we had to set a date for automatic access to the data. The date is 21st of September 2015 for 3 of the hospitals and 10th of October 2014 for University Hospital of Northern Norway, because that was a pilot at that time. But you can ask to get documents open longer back. Now, with this access log, it's sort of a bit more complicated because it's based on this beslutningsstyrt tilgang, so access by decision, and if someone has got access by using this blålys functionality or emergency access. So the date for the first access will vary between the hospitals and units, but the earliest would be from 2009, when the first hospital started to use beslutningsstyrt tilgang or access by decision. On level 2, a specific health professional, what kind of documents has this person opened? As a rule, the log will only be available for those documents that are accessible in the patientjournal, so those documents that are already there. And then applies the dates I was mentioning, 2015 and 2014. Now, this is actually quite difficult to communicate for you and for the patients, what you can actually see. But for everyone, we say that you can see as much information that is, or you should, ideally, as an ideal, you should see as the information that is there. Now we have run a pilot on this service since May, and I will just give you a brief description of what we have found. It was put into production on helsenorge.no since May, and since then more than 50 people has tested the service. In general, people are very happy with the service. They find it's quite understandable, they appreciate it. They see some areas of improvement, especially when it comes to wording, because some of those reasons for access is quite, especially the templates for reasons for access is quite non-understandable. And also users are more concerned by who has accessed their journal, so level 1, than interested in which kind of documents they have actually accessed. And also users don't worry so much about unfamiliar names. A lot of people have accessed the journal. It's not so, well, this is a small number, of course, but it seems not to be so bothersome than as if they find familiar name, if they find their neighbor's name or their aunt's name or something. And also if they find very unexpected names, unexpected roles, and also the time of access. If they see someone has accessed their health record, let's say 2 years after they were hospitalized, they will have questions. So when it comes to understanding the service, this is one example of those phrases that are in the system, which says, I have to read it because I can't remember it by heart, basert på innebygget prioritering mellom beslutninger. Maybe those who know what it means can tell us. Well, it's just very understandable for everyone working inside the system. It's not very understandable for everyone outside the system. Now we're working on that one. Also, when you develop such a service, an access service, you actually get what is there. So this is what is in the database. Some of the names have an or as a prefix, which is it's made for a purpose, for sure. It displays right, it displays what is there, but it looks wrong. So users will say, well, I think something is wrong. This name doesn't appear right. We have to work on that one too. Now, transparency comes with a price. When we launched Pasientjournal almost 1 year ago, actually the first 24 hours, we had the first case of someone finding somebody else's documents in the journal. It shouldn't happen. We know it happens from time to time. We've had, for that year, we know of less than 10 cases, but that's actually 10 cases too many. Now, the good thing is that it's a possibility to correct the wrong things. But of course, it's a distress for those who experience that. For those who has experienced somebody else's documents in the journal, it's been the case of scanning, that has been scanned to different scanned on the wrong person in most cases. So centralized scanning routines is a solution to that one. But we believe that it's really improving the health service because now we know more about where we have mistakes. So right now we are getting ready for the service. We expect, and we don't plan to do a grand opening. We did that last year, and it was not that it didn't work well, but we think we'll do it a bit different this time. But that doesn't mean that it can be a grand opening by itself, because the way social media works, the word can spread very easily. So we have to expect a large number of people who try to log on to the system at the same time. And those people don't care if they live in Oslo and they won't have the service because only Northern Norway that would have it first. Everyone will try to log in to find out if it's working. So we have to be technically prepared for a large number of users. And we also need to ensure that the production will not be affected, that the healthcare professionals won't notice that there's a new patient service being launched. That's also very important for the project and for the hospitals, of course. We have to prepare the hospitals, not only the hospitals, but also Helse, anyone who is in contact with patients. To get more requests on the content of the log. And that's based on the experience we have of launching Pasienttjenester, because what happened then was that the feedback from patients came in all sorts of channels. They were using Facebook, they would post something on somebody's Facebook site, they would ask a secretary, they would ask their doctor, they would ask their primary healthcare physician and so on. So we need to ensure that everyone knows the basic of the service and can reply to the request. And we need to inform, to train, and to take care of employees, because we know that there might be some questions and there might be some suspicion raised on our employees, and they have to be taken care of in a proper way. So, in general, we are prepared for the worst, but actually expect more or less business as usual, because with most e-health services, there's a lot of problem thinking beforehand, and it's actually, luckily, most of the problems are not happening. That's good. So this access log, or this tilgangslog, is one of several building blocks to ensure patients' right to know his or her own health information. So it's a step towards patient empowerment, whatever we define that to be. It can support patient safety, as more transparency can increase patients' trust in the healthcare system. It can ensure patient safety, as the person who has the greatest interest in her own data will also be able to check if it's taken care of properly. And it can improve the quality of the health service, as we believe that the transparency improves trust in the health system. So that was actually all I want to say now, and we are just, I hope that we'll be back, let's say, in 1 year and tell about the experience with the access log and how it will, what patients think about it. Thank you.
Thank you. And again, thank you for leaving a little bit of time to questions. Are there any questions? I can't really see any hands, but I know we have a microphone somewhere. Okay. While you formulate and put together a question in your head, I do have a question. Because there's been a lot of talk about skepticism and criticism from a clinical side towards patients' access to the medical record. And there still is a lot of skepticism, and that is mainly to do with that you have to disclose things that you would previously think that you would be writing to yourself and your colleagues, and you might need to write it in a different way, and so on and so forth. It's not that discussion I want to go into now, but I'm curious to what extent the clinicians are skeptical or critical towards this kind of initiative, because it could be interpreted as a kind of a sort of a mistrust to the clinicians, that they would sort of snook, it's called in Norwegian. They would access the medical record that they shouldn't be allowed to do. Have you any thoughts on that?
Of course, there's always skepticism to new things. I think what really helps is that we have a very good dialogue with the employees through the unions, through Verneombudet, and also it's not a new thing. I mean, everyone knows that everything you do is being logged. So it's just that now it's being visible. But of course, I think most clinicians would say, what do they want it for? More like that. Of course, there might be some people who are skeptic because they are afraid that something is there, but I don't have that impression. And I also think that most clinicians are quite positive. They're saying, well, we will do what we have always done, and this is helping us improving the health service. And I think that's very good. And also some people said, some managers say that, well, we don't meet problems with less information. We meet our problems with more information. And I think that's a very good approach.
Interesting. Still no questions being formulated in your heads? We do have a question up here. I think you were also the last one with the microphone, possibly. You don't have the microphone.
The microphone is gone. People want lunch.
Okay. The microphone is here. It's being handed to you, I think, now. Up there. But I can just say that before you receive the microphone, that representing Southeastern Norway Regional Health Authority is very difficult to say. We think a lot of what you're doing in your region, and we turn our southeastern eyes with great admiration.
You're looking north.
We are looking north, yeah, definitely. So thank you very much for that.
Yeah. No, it's good. We have a good collaboration with all the regions, and I think that's very useful for everyone. Yeah, there was a question.
Yeah, it was
Please
just a comment, because you said that, first of all, that everybody knows that their access are being logged. I'm not that sure that that's the fact. And second of all, I've been working on Kjernejournal now, and there when we implemented that in the emergency call center, the AMK, they chose not to use it. Or they choose not to use it because the names are showing. They have a tradition of keeping that kind of information private, and they don't want to give up their names. So I just wanted to comment that you should be aware that people can get a bit skeptic when they notice that this is a feature.
I know that some people are skeptic. It's just that very often it's drawn the picture that all clinicians are so skeptical, and and it's not really my impression. I know that this, especially what you're mentioning about the names, it's a big debate. It's a big debate in this ward, in other hospitals. And we also had some of those questions when it came to the patient access to the patient journal, that people said, why does my name has to appear in the record? I don't like it. Well, you might not like it, but it's actually there, and it's a legal document. So. And I think it's moving.
Yeah.
It's a way of maturing the attitude for everyone.
Thank you.
All right. Any more questions? Perhaps it's difficult because I believe there is a lunch, and when I've said the word lunch, everyone is sort of getting up slowly. But thank you very much.
Thank you.
Godt for en gave.
I know where they are. Tak skal du ha.
Det er godt. Thanks everyone.